All right, here's a little recap from the first week. We talked a little bit about some chapter 4 stuff, primarily negligence and how it can occur when you had a legal duty to the patient. And that occurs, some people say as soon as we get the call, the dispatch, others say as soon as we make patient contact. But either way, we can't not go on the call. And when we arrive, we do have to determine if we have a patient or not. If we do have a patient, if they had any kind of complaint, any issue whatsoever, then they automatically become our care and we have a legal duty to treat them or determine if they are eligible to refuse our treatment. Okay? There had to have been some kind of breach of duty, as if another reasonable paramedic would have done or would have not done the same thing you did. Um, that failure to act or what you did that was determined to be negligent caused that patient to have an injury. And remember, an injury can be anything like a financial, emotional, or physical type of injury that the courts are going to look at. And then last of all, there has to be some kind of harm resulted, and that keys back into injury. There has to be something that that patient has a complaint about that you did directly. Okay, that's how negligence is proved. Slide. Um, Three basic categories of negligence. Malfeasance is doing something that you are trained to do. I'm sorry, doing something that you are not trained to do whatsoever in any of your scope of practice. So, in other words, if you attempt to suture somebody on scene or just something silly like that, and that was a direct cause of the harm that was occurred on the patient, all right? If it's misfeasance, you did something that you were trained to do, but you did it grossly wrong, whether it's an intubation or an IV or an IO or pushing a medicine or any kind of scope of practice um, event that you did in a wrong way, okay? And then with nonfeasance, it's not doing something that you should have done, kind of an omission, whether you missed an airway issue, you neglected to push the right drug, or even taking care of the patient in the proper manner, anything like that. Got it. All right, let's talk. We talked a little bit about some of the main electrolytes you guys need to know about: the sodium, potassium, calcium, and magnesium. Be familiar with them, what they're going to do in the body. It's going to be touched on more as we go through the program, especially with pharmacology and cardiology. But get these basic principles with the individual electrolytes down, okay? I'm not going to talk about them because you guys can read. All right, some electrolyte, how they correspond with acids, and the entire pH scale was talked about as well. So have a basic understanding of this. I don't expect you guys to be chemists by any means, but you do have to understand what factors can make the body acidotic, and in turn, what factors can make the body alkalotic. We talked a little bit about how the respiratory drive is the main way the body can handle an excess of acid in the body by blowing off CO2. That CO2 is used to bond with other molecules in the body to create more acid. So if the body essentially dumps off those specific molecules, the building pieces won't be there for the body to make the acid. All right, and that in turn talks about cellular respiration. Remember, it's not the cell breathing, but it's the cell exchanging chemicals across barriers or interacting with chemicals and exchanging them across the barriers. All right. The primary one we're worried about is how the cell gets its energy from oxygen and glucose, and then it produces that waste as carbon dioxide. Has to dispose of that. The less it disposes of, the more acids will be formed in the body, increasing the overall acid levels in the body. Got to have just a basic understanding of that for now. Again, the definition of respiration as opposed to ventilation. Ventilation is the active moving of oxygen in and carbon dioxide out of the body. And when we talk about respiration, that's the exchange of gases. So whether it's oxygen, carbon dioxide, any kind of gas exchange between that living organism and the environment, all right? So when we talk about respiratory rate, it's really not the correct term to use per se. It's more of a ventilatory rate. We do worry about respiratory or respiration anomalies, whether it's some kind of issue at the cellular level or the alveolar level or the capillary level, where there's some kind of mismatch of respirations there. Excuse me. All right, some external respirations. When you breathe air in, air goes into those alveoli. Oxygen and CO2 are exchanged at that alveolar and capillary level. That's an external respiration because essentially that alveolar capsule is still exposed. If you think about how it goes in the mouth, down the trachea, and the bronchioles, all the way down, there's still that open air external site there, okay? Internal respiration takes place at that cellular level when the capillaries get down to that cell level and they're exchanging oxygen and CO2 at that cellular level. Easy peasy there. The role of diffusion is one of the big times we think about diffusion in the body. It's essentially a process of a gas going from a high concentration to a low concentration. If the body recognizes that the cells need oxygen and there's more oxygen on that red blood cell, the oxygen is going to diffuse across and get into those cells. Concurrently, if there's more CO2 in those cells than there is on that red blood cell, the CO2 is going to diffuse across that barrier right there. Nature doesn't like to have a mismatch of pressures, so essentially it goes from an area of high pressure, high concentration to an area of low pressure, low concentration to equalize that balance. It's not like every single CO2 molecule and every O2 molecule comes off automatically, but it equalizes as it goes through the bloodstream there. Same thing happens at that alveolar level when we breathe the air in. Okay, when it comes to the major skeleton parts you need to know, here we go with this. When we look at the skull and the features of the skull bones, you need to know the various geographic areas of the skull as it applies to when we document where injuries are, where things are that are going wrong on the scalp. So the frontal, parietal, temporal bones, as we go toward the rear of the skull, the occipital bone. Know the difference between the mandible and the maxilla. Don't worry about the ethmoid, the vomer, the zygomatic, or anything like that. But know, if you're going to document this, you would call this the orbital circle, or the nasal bones, things like that. All right. Remember, we love we don't love it, but we're dealing with it when it comes to the foramen magnum. That's where the medulla goes down and begins to form the spine. The spinal column as it goes down there. That's it for the skull. All right, there's that foramen again. Knew those. You don't have to know all of these different processes inside of the skull, but I just wanted to give you a good documentation or a good visualization of that foramen again. All right. Vertebral column, you got to know the different divisions of it: 7, 12, 5, and 5. Sorry, that was supposed to happen. Why isn't it going back? Anyway, just know those divisions of the spine. When it comes to the thorax, know these divisions of the ribs, where the clavicle is, where the suprasternal notch is, the manubrium, the body of the sternum, and last but not least the xiphoid. Okay, and that all fits in the diaphragm. Remember, the space underneath here is called the oh god dang it, the mediastinum. All right, contains the heart and the great vessels underneath there. All right, again, another view of the ribs and the sternum and the xiphoid and all that. You're going to have to know the various intercostal spaces when it comes to decompression, when it comes to putting on 12 leads, being able to document where injuries are, where penetrating wounds are, and that kind of stuff. Easy to know the scapula, you don't have to worry about that. And then the rear divisions of the intercostals as well. The appendicular skeleton, really, if you know the clavicle, the humerus, the shoulder joint in there, how they fit in there together, just be able to recognize that and recognize when there's a deformity of that. Don't have to know all these other little names of the bones over here. Just major, large bones. All right. Arm bones, humerus, radius, ulna. Not going to make you memorize all the different bones in the hand, but everybody knows how to document what finger is injured, where that joint is injured, whatever it is. Okay. Pelvic girdle, we understand what the pelvic girdle is built of. The coccyx, the sacrum, or the end of that, the iliac crest, the major ischium in there. Excuse me. I think I'm getting a cold. All right, low extremity wise, femur, patella, fibula, tibia. Good there. Don't worry about the individual bones of the foot, ankle, and foot. Good there.